So these are the targets. I was asked to avoid EGFR mutations, so I am. So ALK. ALK is shown here. It occurs in, as the slide shows, 3 to 5% of patients, initially described in anaplastic large cell lymphoma, seen in a few other solid tumors. This is the demographic of the ALK population. It tends to be the younger patients. There's roughly equal distribution between men and women, whereas EGFR mutations are more common in women. Mostly never smokers. If your pathologist at Tumor Board says this is an adeno with signet ring histology, think ALK. That was actually a question on my recertification boards that happily I passed in October. That should trigger it. Here's the signet ring. You see the arrow here. I can't see it from my angle. I can see it on my screen here. We're not going to talk about best diagnostic test, but just to be aware, there's a wave of antibodies used in IHC that may replace FISH, but right now this is the break-apart FISH assay, which we identify these patients. This is a targetable genotype. Crizotinib, the small molecule, actually inhibits a number of targets. Shown on the slide here is MET, ALK, and ROS1, which we'll get to ROS1 in a second. Scott alluded to the fact that we have very large phase 1 trials. Here's another one. And this is the updated data in Lancet Oncology, looking at the waterfall plot. What oncologist doesn't love that waterfall plot, particularly in lung cancer that was typically treated second, third, fourth line setting, in which we didn't really have any good therapies for this ALK positive population. And you see here estimated survival in that setting, 3 out of 4 patients alive a year after use of this drug, in a median PFS of about 10 months, whereas cytotoxic therapy, you're talking about probably an average of about 2 months till progression. So active. This was some data at ASCO last year from the phase 2, extending this from phase 1 to phase 2, very similar phenomenon in ALK positive patients. As I mentioned before, though, the true test doesn't come till phase 3. We have 2 trials. This one here, still outstanding. This is a first-line trial in ALK positive patients, randomized to the control arm of platinum pemetrexed, likely the preferred agent in this setting, versus crizotinib. And the trial that we now have some data on, Profile 1007, was a second-line trial in ALK-positive patients who had received 1 prior regimen, randomized to physician choice of standard second-line cytotoxic versus crizotinib. The primary endpoint of that trial was progression-free survival, and here is the primary endpoint, PFS by independent radiologic review. Obviously, a significant, both statistically and clinically, with a hazard ratio of 0.49 in favor of the targeted agent in this targeted population compared to standard chemotherapy options. So I would argue this is the second identified genotype in lung cancer, EGFR being the first, where a targeted agent yields better outcomes compared to our standard cytotoxic chemotherapy approach in this particular setting. Now, there was some retrospective data in the literature suggesting that ALK-positive patients receiving pemetrexed did better than those receiving other agents, and you see here that was actually borne out here. This is the PFS curve. Obviously, crizotinib wins, but if you look at the difference between PEM and docetaxel, there was an advantage for the PEM arm, both in PFS as well as overall response rates. Here you see the difference in objective response rate, 20%. This is, again, second line. So 20% in second line in phase 3 is twice as good as what we've typically seen in a lung cancer trial, 65% in the crizotinib arm, but a differential expression, 6.3% is typically what we're used to in the second-line setting with cytotoxic drugs. So you see here 29% for pemetrexed, obviously not quite where crizotinib should be. Again, this trial had a high rate of crossover. Again, one might argue that maybe it doesn't matter when you get it, it's if you get it. So the importance is identifying these patients and making sure they get it at some time. But when you look at patient-reported outcomes and the quality of life, obviously all of these quality of life domains favored crizotinib versus cytotoxic chemotherapy. And here's just some of the toxicity data, and I just show this to show just really how well tolerated this agent is compared to standard cytotoxic chemotherapy. So again, we've made inroads in the crizotinib population. Obviously, I think it's fair to say that crizotinib may not be the best ALK inhibitor out there, and there are others coming. I think probably the two that lead the charge right now are the LDK Novartis drug and the Chugai drug, now licensed in the U.S. By Roche. We had some interesting data at ASCO last year looking at this. This kind of got lost in the lung cancer community because it was presented in the phase 1 session. But this agent looks like it's a more potent inhibitor of ALK than others. And I think the proof of the pudding here is the response rates. And I'll just draw your attention in the interest of time to the second bullet here. 80% response rate following progression on crizotinib. So if you have your ALK patients out there and they start to progress, I would be looking for a clinical trial with either LDK or the Chugai compound to send those patients to. Another class of agents here just to be aware of in the ALK population, this is the initial reports looking at 3 agents in the HSP90 class of drugs, IPI 504, the AUI 922, and gantenerumab, all here done in molecularly defined populations. And you see when you look at overall response rate and disease control by genotype, it was really the ALK population that seems to be most sensitive to these drugs. So this is another idea for your ALK-positive patients in terms of clinical trials, and ongoing clinical trials are out there for these patients. Now, ROS1. ROS1, again, is probably half as common as ALK. It is very similar to ALK. This is the kinome tree. If you look at where ALK is and ROS, they're kind of neighbors. If I remember correctly, the ROS protein is about 50% homologous, but in the kinase domain, it's close to 90% homologous with ALK. When you look at the same chart I showed you before, crizotinib in the ROS1 population, here I've highlighted this here. This is an active agent. We saw some data. This is an outdated slide. There are now probably at least twice as many patients on this trial. But when you look at the early results with crizotinib and ROS1, they really mirror the results that were seen with crizotinib in the ALK population. You see here this waterfall plot shows some impressive activity in this ROS1 population. This is actually a patient of mine who's now out about 14 months or so from when we started ROS1 in the 4th-line setting. At this time point, he had enrolled in a hospice program, and I convinced him to take crizotinib. It was amazing his insurance company paid for crizotinib, but they were swayed by the JCO publication in the same month, and they were able to get him. And this is his scan 6 weeks later. I can tell you his scan on January 23rd of this year looks the same. He's fully ambulatory. He's a college professor, and he's back teaching. So he's done well, and he has no suggestion of any progression now 14 months out from that. So identifying these patients, I think, is important in our setting. BRAF, as you well know, this was just described about 10 years ago. Most of the BRAF mutations occur in melanoma, where the majority of them are this V600E variant. This is a serine threonine kinase. There are several RAF family members. This sits downstream from RAS and is with mutations can be constitutively activated in this particular setting. We have at least 2 reports when I made this slide looking at BRAF and non-small cell lung cancer, both published in the JCO a couple years ago. Large number of patients you see here. Some clinical characteristics here. It was mutually exclusive of other genotypes. In this V600E, not quite as prevalent in non-small cell as in melanoma, and roughly the same data by the other publication here mirroring this sort of thing. And this is actually just a table from the most recent analysis of the Lung Cancer Mutation Consortium, where they were to take 1,000 adenocarcinomas and genotype them, and you see BRAF sitting here at about 2%. Now, I mentioned here, and 50% of you got the question right. Here's the data in melanoma, where the vast majority are of the V600E. Here in the data to date in non-small cell suggests a lower prevalence of this particular variant compared to others. And what the significance of that is yet, I think, is still to be determined in this particular setting. We all know there are BRAF inhibitors out here. Vemurafenib is here, approved for melanoma. The one that's being studied in the Lung Cancer Mutation Consortium here is the GSK drug dabrafenib, and we've submitted an ASCO abstract for this year that I think will be quite intriguing, although we can't talk about the data, but let me show you one of my patients here. Again, here's her disease, and then 8 weeks later, she had her treatment is up here. So again, not surprisingly, in a driver, felt to be a driver mutation, you see activity of a targeted agent in this setting. Switching to c-MET. c-MET is, again, another tyrosine kinase receptor. It actually plays quite an important role in tumor cell migration, invasion, proliferation, and angiogenesis. The only known ligand for this is hepatocyte growth factor. In non-small cell, I think the data to date, although I don't know that we have enough data about what this means in non-small cell lung cancer, felt to be a prognostic indicator. And obviously in the mutation-positive patients, it's one mechanism of resistance to the use of EGFR kinase inhibitors in this particular setting. Now, there are several different ways in which MET can be looked at. It can be looked in terms of the mutation. These are exceedingly uncommon, but do occur in non-small cell lung cancer. MET increased expression, which is, again, commonly found here. And then the autocrine production of HGF has been demonstrated in a number of tumors too, not necessarily in non-small cell lung cancer. So a couple different ways to look at MET, whether it's just expression versus mutation. By virtue of the number of companies that are interested in this pathway, it's got to be important if all these companies are looking at it. You see here, do we really need all of these drugs? I will tell you that the initial forage into this setting is the Marquis trial. This actually was based on what was felt to be a positive randomized phase 2, adding the Arcule compound here, ARC-197 or tuvantinib, to erlotinib versus erlotinib alone. Now, it turns out tuvantinib may not be a MET inhibitor, so that's a problem. It was done here in the second, third line setting. In their phase 2, they, other than using histology as the biomarker, there was nothing moved forward. Obviously, they collected tissue. However, based upon selecting adenocarcinoma patients, this was a completely negative trial. Now, maybe some of my colleagues have seen the data, but obviously I think tissue was a requirement for this trial, so we have a lot to learn about the molecular aspects of this. Histology may not be the best biomarker for these sorts of things, but this, at least initially, targeting MET was a completely negative experience. This is the other major effort at the current time. METMAB is a monovalent antibody to the c-MET receptor. This is the phase 2 data that was led by Dave Spiegel. Again, grafting METMAB onto erlotinib in the second line setting. The interesting thing is they had a companion diagnostic using immunohistochemistry, kind of worked that out before the trial, and so had a co-primary endpoint looking at the MET diagnostic negative versus positive trials. And when you look at what was felt to be MET diagnostic positive patients, so this is using IHC, and this was about 52% of the population. So it's about half and half. You exclude half the patients based upon protein expression in this setting. And you see both hazard ratios for PFS, actually a little better for OS, are in favor of the combination with erlotinib versus erlotinib alone. So in this now in the MET diagnostic population, which I did not choose to show you, there was no effect to possibly a harmful effect, which is not quite understood, nor was it anticipated. But maybe some of you are participating. We are putting patients on this trial at Pittsburgh. This is the phase 3 trial that is done not with histology as the biomarker, but with sending the patient's tumor to a central lab and testing for MET protein expression. And when you get back that test, which is 50-50, you're MET diagnostically positive, they can then go on to this trial. So I think this is an important trial in light of the tuvantinib trial. And perhaps by using this marker, which kind of gets rid of half of the population, this trial may have a better chance, but we don't know. I mean, it's accruing quite well, so hopefully we won't have to wait long for the answer. RET, not much to say yet about RET. I think many of you are familiar with the story in thyroid cancer. I'm going to move pretty quickly through some of these slides in the interest of time. In non-small cell lung cancer, it mostly is translocated with the KIF oncogene. There are diagnostic FISH tests for this. This is something that we routinely do at our particular center. Again, like other genotypes, this occurs in a small percentage of patients. This was a surgical series published in the JCO last year. Large number of cases, about 1% to 2%. You see here the histology, mostly adenos and so on and so forth, mostly poorly differentiated younger tumors, never smokers, so on and so forth. And there are a number, this may be hard to read back there, but there are a number of RET inhibitors, and one of these drugs, the XL184 drug, is going to be studied in the Lung Cancer Mutation Consortium, specifically in the RET positive population. So we don't have any clinical data yet, although there's certainly been examples in the literature and at meetings of patients with RET abnormalities responding to RET inhibitors. And lastly, PI3 kinase. Again, this is a depiction of the PI3-AKT-mTOR pathway. And again, multiple potential targets in this particular pathway. We talked a little bit about this in the squamous population. This is actually a rather complicated pathway here with a number of different steps. And I will just point out here, this is a very nice review article by Valley, I'm not going to say her last name, Valley from MD Anderson, and just looking at, we've talked about PTEN and PI3 kinase here, and this is fairly prevalent in non-small cell lung cancer. So knowing this and knowing the fact that we have a number of PI3 kinase inhibitors, and I've kind of listed them on this slide here, the multiple options one has to target this particular pathway at several different levels. So this is actually going to be, I think, quite complex in sorting this pathway out. There are multiple potential targets here, and how to optimally approach this prospectively, I think, is still to be determined. There are a number of inhibitors, as I've mentioned here. This is not a complete list, but you see the list and some of their dose-limiting toxicities and the activity that's been seen. It's quite early, at least in non-small cell lung cancer to date in this particular setting. This is actually, BKM120 is actually being studied in the Lung Cancer Mutation Consortium at this particular time. So, last slide, beyond EGFR, there are several other potentially actionable genotypes. Crizotinib active in ALK and ROS1 translocated patients. We're also doing a study. Remember, this is initially developed as a MET inhibitor. Certainly in MET, either amplified or mutated populations, this is being looked at. BRAF mutations, obviously there's an approved BRAF inhibitor in melanoma, but others are coming, and you'll see some interesting data at ASCO this year in this selection or subpopulation of non-small cell lung cancer. And I guess, you know, we have made a lot of inroads in the non-squamous population, molecularly defining the patients and targeted them, and I think both EGFR and ALK were the initial very positive studies. You got to look for these patients. You can't tell by holding their hand in the exam room whether they have one of these. You got to get tissue to test. The question is, you know, how far do you cast the net? Do you do, you know, next-gen sequencing to look for these, where you get 300 other things that you don't know what to do with? Or should it be more tailored? We at Pittsburgh start with a panel of 8 identifiable genotypes, 3 of which we think are actionable. The other 5 identify patients for clinical trials. If we come up 0 for 8, we then do next-gen sequencing on those population. But again, I think all of us are struggling with the optimal way and what you do with a lot of this information, which isn't always clear. Thank you.